Welcome, and thank you for participating in today's event, the Ohio Academy of Family Physicians Breast and Cervical Cancer Screenings for Female and Transgender Patients. I'm Mary Krebs, a family physician. I'm an OAFP board member, and I am currently the Medical Director of Primary Care at Cohere Health. On behalf of our membership, it is my honor to moderate today's session. According to the American Cancer Society, nearly 44,000 women will die from breast cancer, and more than 4,000 women will die from cervical cancer in the United States in 2021. Many of these deaths can be prevented if breast and cervical cancer screening rates increased among women at risk, and that's what we're learning about today. We're saving lives. The Ohio Department of Health's Breast and Cervical Cancer Project, BCCP, can financially assist those eligible in Ohio in obtaining breast and cervical cancer screening and diagnostic procedures. In addition, their patient navigation program also provides guidance in navigating the healthcare system, finding community resources, answering questions about scheduling appointments, using insurance, and more, regardless of eligibility. So they're here to help. To make these services available, the BCCP partners with approximately 500 medical, clinical, and lab providers in Ohio. To provide an opportunity for Ohio's family physicians and their practice teams to learn more about breast and cervical cancer and their screening and the BCCP program, OAFP is offering 3 continuing medical education webinars free of charge to those who are interested. For the first session today, our speaker is Dr. Bethany Panchal. Dr. Panchal is a family physician at The Ohio State University Wexner Medical Center, specializing in women's health, including obstetrical care and preventative health care. For today's session, Dr. Panchal will outline the screening recommendations for breast and cervical cancers. She'll define the breast and cervical cancer screening needs of transgender patients. She'll cover cancer screening guideline differences for normal and high-risk individuals, and review web-based resources for calculating cancer risk scores for individuals. So let's go ahead and get started. Dr. Panchal, take it away.
All right. Thank you, Dr. Krebs, for that introduction. And thank you to the OAFP for inviting me to give this talk. I really appreciate the opportunity to do it. And hopefully we all can learn a few more new things today. So I am an associate professor of family medicine at The Ohio State University. And I'm also an associate residency director at the residency program. And in addition, I am a vice chair for diversity, equity, and inclusion. So hopefully we can do a little bit of discussion on equity as well. So I have no disclosures. And we already reviewed a little bit of the objectives today. So I'm going to move forward. So first of all, let's talk a little bit about the statistics. So we know that the breast cancer is one of the most commonly diagnosed cancer in the United States in women. It's also the second highest cancer-related death in US women. This year, as Dr. Krebs has already told us, so this year the American Cancer Society estimates that over 280,000 new cases of invasive breast cancer will be diagnosed in women. Almost 50,000 new cases of ductal carcinoma, and over 43,000 women will die from breast cancer alone. 1 in 8 women in the United States will develop invasive breast cancer in the course of her lifetime. So those numbers are quite concerning. So this is why we're here today, to talk about breast cancer screening and the recommendations. Well, maybe you're like me, and over the last several years, I've been confused. There are so many new and changing recommendations coming out, and it's hard to keep up at times. So hopefully today we'll do a little bit of a better job of kind of reviewing what all of these recommendations are, and maybe you can choose the ones that you like the best. All right, so first let's start with the normal risk guidelines. There are several colleges and societies that have put out recommendations specifically for breast cancer screening. The USPSTF in 2016 guidelines changed to recommending breast cancer mammography every 2 years for women starting at the age of 50. Now, there is an update in progress, so I would imagine there's probably going to be new guidelines coming out either this year or next year. The AAFP does support this guideline recommendation. Next, a C recommendation that if you want to start mammography before the age of 50, that it really needs to be a discussion between the physician and the patient and make it an individual one. The American Cancer Society's last update was in 2015, and they recommend annual screening mammogram between the ages of 45 to 54. And then after the age of 55, having mammogram every 2 years. And in addition, women between the ages of 40 and 45, they should be given the choice. More recently, the American College of Physicians, their recommendations are starting from the age of 50 because they have found that the most significant benefit is for biennial mammography to reduce mortality. And we'll talk a little bit more about that. At the age of 40, mammography should be discussed, though we have come to find in some studies that the harms may actually outweigh benefits in this age range. And women over the age of 75 or having a life expectancy less than 10 years should not be screened. They also go on to note that they do not recommend clinical breast exams. So again, there's some more. So the American College of Obstetrics and Gynecologists, they recommend starting annual or biennial mammography starting at the age of 50. And that one is to offer it to your patients, and then recommending mammography starting at the age of 50 to 74. After the age of 74, making it a shared decision between you and the patient, yes. And then the National Comprehensive Care Network and the American College of Radiologists, they are sticking to annual mammography starting at the age of 40. So I wanted to put this kind of to you here. This table is actually from a recent article in the AFP that you can find, and it goes through each of the different societies and colleges and what their recommendations are, and how do they differ and how are they the same. So it's a really good resource if you can get that. So let's talk a little bit about the screening guidelines and where the evidence is. How does screening really affect mortality? Modeling studies report that the number needed to screen with traditional mammography to prevent one breast cancer death runs from 746 in women the ages of 40 to 233 for women ages 60 to 69. So I really want to bring our attention to this age here where we see the most benefit. So the USPSTF actually uses the randomized controlled trials, and it actually indicates a much higher number needed to screen. So the study calculates that per 10,000 women screened, over 10 years in women ages 40 to 49, only 3 breast cancer deaths would be avoided. And then, so we again see the most benefit here in women ages 60 to 69 in preventing 21 breast cancer deaths per 10,000. So now that we've talked about the guidelines, we've talked about what are the evidence behind the screening, we can't continue to talk about screening unless we know what the harms are. So there are potential harms to screening. And one of the ones is false positives. So we do see more false positives with annual mammography versus mammography every 2 years. Also, women who have dense breasts, women in the ages between 40 and 49, and those on combined hormonal therapy are also more likely to have false positives. So false positives also leads to overdiagnosis. So that will lead to women having more imaging and more procedures that may not have been necessary. This again leads to anxiety and distress on the patients and on the physician's part, let's be honest. And then of course, in the screening itself, mammography is not a comfortable position to be in for most women. So, so those are some of the downfalls to the screening process. So it really is a risk-benefit discussion to have with your patient. But this does not really cover screening for our high-risk patients. So we do need to talk about that separately. So the strongest risk factors leading for breast cancer in developing breast cancer is older age, gene mutations, specifically the BRCA genes, having a history of chest radiation, especially as a child, having family history, and then women with increased breast density. Now, these are all risk factors, and of course, there's more risk factors that can add to that lifetime risk, but it needs to be noted that most women who are diagnosed with invasive breast cancer actually have no risk factors whatsoever. So we got to keep that in mind. So how do we determine risk? There's actually some really good tools online that we can use. This is the one that I use mostly, and it's the Gale model, and it's available on cancer.gov for free. It's an online tool, and it goes through several different risk factors in your patient, including, of course, age, but also if she's ever had a biopsy or a family history, known gene mutation, anything like that. And it'll give you a risk assessment at the end. The next one, the International Breast Cancer Intervention Study, or IBIS model, is an online downloadable program. So there are updates that you will have to keep doing as the program changes. But this is a more comprehensive risk assessment evaluator and goes to really good detail as far as developing a risk score for patients. And then the Breast Cancer Surveillance Consortium module, again, is an online tool that is free that can be used. And it actually goes through just maybe like 10 different risk factors to give you a risk assessment. So maybe better for the lower risk patients. So the thing, no matter which tool that you decide to use, these are important things that we can use as physicians to help our patients and to determine a plan for them when it comes to screening or genetic testing or chemo prevention. The nice thing about these tools is that they do have a pretty good negative predictive value of 97% or more. So now that we know how to screen and we know how to assess for risk in our patients, I want to talk now about screening recommendations for those patients, and specifically the patients who have a greater than 20% lifetime risk, so the really high risk patients. So the American Cancer Society recommends offering annual mammography and MRI with contrast starting at the age of 30. ACOG, they add in clinical breast exam every 6 to 12 months between the ages of 25 to 29, and then adding in annual MRI with contrast starting at age 25, and then annual mammography on top of that starting at age 30. American College of Radiologists, their recommendation, they don't say anything about the exams, but they do recommend annual mammography with MRI starting at the age of 30. Now, the National Cancer Network, they do also recommend the clinical breast exam every 6 to 12 months, but starting at 21, annual MRI starting at age 25, and mammogram starting at age 30. They also go on to talk about specifically chest radiation, and they would recommend that a clinical breast exam actually be started 10 years from the last radiation and be completed every 6 to 12 months. And then once the patient hits the ages as above, to start those recommendations. So what that means is if you had a patient who at the age of 5 had chest radiation for a childhood cancer or whatnot, then at age 15 to start those clinical breast exams. And then the USPSTF and AAFP, they make no recommendations at this point when it comes to specifically breast MRI for screening due to insufficient data. So these are just these are the guidelines there for the high risk patients. And you may want to, when you do have a patient with a 20% or higher breast cancer risk score, I tend to send those patients on to genetic counseling, and even at Ohio State, we're very fortunate to have a high-risk breast clinic that they can get even more detailed assessments and plans for that they can follow up with their physicians. So next, I want to review what are the different screening modalities. I'm not going to spend too much time on this, but I do want you all to be aware. Clinical breast exams. Okay, so first of all, let's start with the self breast exams. So USPSTF and AAFP recommend against teaching self breast exams. But ACOG, National Cancer Network, and the American Cancer Society really encourage breast awareness. So kind of talking with our patients about being aware of their breasts and the changes that their breasts can go through so that they may note anything that is abnormal. And they really base this on a survey that was completed in 2003, where out of 361 breast cancer survivors, 43% of them reported detecting their own cancers. When it comes to clinical breast exams, again, the different societies recommend differently, and ACOG, they recommend offering it at least every 1 to 3 years. National Comprehensive Cancer Network recommends doing it every year. USPSTF and the AAFP do not make a recommendation due to insufficient data. Mammography is the gold standard for initial screening. It is the most studied form of imaging, and it's the only one to show a decrease in breast cancer mortality. There are different modalities. There is the 2D, which is the standard, and that can be on film or digital. And then the 3D, which is also called digital tomosynthesis. And really, the choosing between these is dependent on the availability of where you are, if they have the digital available or the 3D available. We think that digital and the tomosynthesis may be better for women with dense breasts because it does have a little bit higher sensitivity. Okay, so, but I guess with increased sensitivity, there also is that risk for higher false positive rates, as we've discussed already. The next one is the automated whole breast ultrasound, which this has kind of really started to come out maybe in the past couple of years. And what this does is creates a 3D picture of the breast using ultrasound. And specifically, this can be used in women with dense breasts again, in addition to mammography. American College of Radiology recommends considering this in addition to mammography, really based on a trial that showed improved detection rates in women with dense breasts compared to mammography alone. So 75% sensitivity versus 52% sensitivity. And again, we know that with that increased sensitivity does increase the false positive rate. So keeping that in mind when you are talking with your patient about the risk benefit. MRI increases sensitivity for detecting breast cancer specifically in high risk population versus mammography. It is less specific though compared to mammography, so that does result in higher rates of false positives. So recommendations for screening MRIs are really for women with that greater than 20% lifetime risk. Okay, so now maybe you're looking like this at the computer, and I'm kind of imagining it because I just went through so many different societies and colleges about the different screening recommendations that they have. And we haven't even touched on transgender, and I will do that at the end. But this is really where shared decision-making comes in. Talking with our patients, really doing that individual risk assessment and knowing what it is that, what you recommend, what they would like. Do they want to do annual mammograms, or should you recommend mammograms every 2 years? When should you start? When should you stop? I've given you the tools to make these decisions. You can find other ways to kind of help you make these recommendations, but in the end, it should be a discussion between you and your patient. So I want to take a breather right now and let everyone kind of sink in what we just talked about, because we're going to move on to the next subject, which is cervical cancer. Okay, so cervical cancer. American Cancer Society estimates that over 14,000 new cases of cervical cancer will occur in the United States this year. And then we will also have over 4,000 deaths due to cervical cancer. We know that the risk for development of precancerous lesions does vary by the type of HPV virus. And HPV virus causes almost all cervical cancers, with 70% of those being caused by two different types, the 16 and the 18. So let's have a little history lesson here, first of all, when it comes to cervical cancer, because so much has changed just in the last 100 years. So in the 30s and 40s, cervical cancer was a leading cause of death in women. So Dr. Papanicolaou came up with his test, and he developed in the 40s, and it was actually implemented in the United States in the 50s. And since that time period, cervical cancer incidence has decreased by 70%. So I wanted to give you a little visualization of what we have seen happen from the onset of implementing Pap smear testing and cytology to the incidence of cancer, cervical cancer, since 1975 all the way to 2005. And over these almost 100 years, there has been a lot of changes in how we screen patients. So in the 90s, the conventional Pap test was actually replaced with a liquid-based cytology. And this was due to increased sensitivity of the liquid-based cytology. Then in 1983, HPV was discovered on cervical cancer tissue. And as we began to learn more and more about HPV and the different typing, we have found out that persistent infection with the high-risk HPVs, and mostly it's the 16 and 18, is the cause for almost all cervical cancers. But what we've also learned that it is the long period between HPV infection there is a long period between the infection to the actual development of cervical cancer. So that is what has made it really possible for screening to be effective in both reducing incidence and mortality. So as physicians, specifically primary care physicians, we talk about screening, but we also need to talk about primary prevention. So what do we have in our tool belt for primary prevention of cervical cancer? And that is vaccination. We should be talking with our patients about vaccinating against the HPV virus. It is recommended for all patients, non-gender, between the ages of 9 and 26. And actually routinely given between 11 and 12. So give it with the Tdap and the meningococcal at that visit. And then we should also be offering it to our at-risk patients up through the age of 45. And let's talk about who's at risk. Well, any patient with a new sexual partner is at risk for getting a new HPV infection. So these vaccines should be given to everyone to the age of 45, pretty much. So let's talk about now cervical cancer screening, because this has also changed. The guidelines have also changed over the last several years. Really, the primary goal of cervical cancer screening is to detect treatable cervical abnormalities in precancer, so the CIN 2 and 3s and the adenocarcinoma in situs. Secondary goal is really to detect that invasive disease. USPSTF last guideline update was in 2018. They recommend starting at the age of 21, regardless of when first sexual intercourse was. And that should be cytology alone every 3 years from age 21 to 29. And then adding HPV to that, or co-testing, can be done every 5 years as long as the results are negative. And that's from the ages of 30 to 65. But you can also continue doing cytology alone, and that still needs to be every 3 years given negative results. When can we stop? We're going to talk more about that soon, but in general, if a woman has had a hysterectomy with her cervix being removed as well, and she has no history of high-grade lesion or cervical cancer, she can stop Pap smear screening. And then women after the age of 65, as long as they've had adequate previous screening and they're not otherwise high risk for cervical cancer, can also stop. Just last year, the American Cancer Society with the American Society for Colposcopy and Cervical Pathology came up with some brand new guidelines. They actually recommend starting at the age of 25. And specifically, starting at age 25, doing a primary HPV test only. And as long as that's negative, it can be done every 5 years. They also say that it is acceptable to continue doing co-testing, but again, starting that at the age of 25, and as long as it's negative, can be every 5 years. And if you continue to prefer to do cytology alone, that obviously can also be done, but again, it needs to be done every 3 years as long as it's negative. Age 65 and up, no testing as long as previous testing series are all normal. So the USPSTF and the ASCCP agree upon the age of stopping, but we'll talk more about what that means as far as when they can stop. So when can you stop? So what's adequate screening? Because that's when they say you can stop. So adequate screening, you need to have 2 consecutive negative HPV or co-testing results. Or 3 consecutive negative cytology results. So if you're doing the co-testing, you have to have 2 negatives. If you're doing the cytology only, you'd have to have 3 negatives. And these have to be within the last 10 years, with the last test being within that recommended interval for the test used. So if you're doing co-testing, then the last test needs to have been within the past 5 years. If it's been longer than that, then you need to do at least one more cervical cancer screen. And of course, these guidelines don't apply for individuals that are under current surveillance for abnormal results. They need to continue to be watched according to the ASCCP algorithms. Otherwise, when to stop, individuals that are over the age of 65 and they don't have any conditions limiting life expectancy, and as long as they've had sufficient documentation. So if they don't have the limiting life expectancy, but they don't have sufficient documentation, they should be screened until the criteria can be met. So like I said, if we don't have any documentation on them, then we need to continue screening. But if you do have an individual that has a limited life expectancy, then that can be stopped. So let's talk a little bit about what is cytology versus HPV testing. Cytology is, as we know, examination of cervical cells under the microscope. And then the HPV test detects the HPV. Sorry, it looks like I deleted something there and didn't realize it. So that obviously detects it through the DNA sample. So it gets the DNA of the HPV typing. And then co-testing actually combines the above 2 tests into one sample. Randomized controlled trials show that cytology alone is actually less sensitive than high-risk HPV only, or co-testing for that matter, for CIN 2 and 3. So it is recommended to at least add that HPV testing to the cytology. However, high-risk alone also had more false positives. So that also ended up in higher rates of colposcopy. So again, there's always a downside to the different screenings. Now, recently there have been some studies done on self-collection. This is specifically for HPV testing because there is no need to get a cervical sample. You just need to get a cervical vaginal sample to test for the DNA. Most of the research at this point has been done in resource limited regions. Specifically, there's a big study going on in Mexico. And it revealed that there is actually a higher compliance rate with individuals doing self-collection versus it being done by a provider. So 98% of the women in the study did actually followed through with their self-testing versus only 89% following through with the provider collected testing. And the self-testing, what you do, you can get it from different samples. It can be taken off a tampon, a cotton swab, a cyto brush, or doing a cervicovaginal lavage. So different methods for actually obtaining the sample. So stay tuned on this one because as the studies keep coming out, I would say that this is something that probably we may start offering here in the United States on a regular basis. So let's talk about some special populations in regards to cervical cancer screening. So women who have had a past history of precancers, the CIN2 or 3s, or actual cancer lesions, they need to continue screening for at least 20 years past that last abnormal. So if they had an abnormal at the age of 50, they need to continue to be screened at least to the age of 70. And then there are individual patients and their risk factors that may require more intensive screening, and it does depend on that history and risk factor. So who is at higher risk? We have extensive research into patients who are HIV positives, pardon me, but also some research that we have with immunosuppressed patients. So transplant recipients or patients who are on immunosuppressive therapy. So CDC recommendations are mainly based upon HIV positive patients, but you can implement this in your immunosuppressed patients as well. And they recommend that women under the age of 30 begin cytology screening within 1 year of the onset of sexual activity or by the age of 21. So that is actually much earlier than in your regular low risk population. And then at least initially should be done every 6 to 12 months until there has been 3 negative tests in a row. And then after that, it should be completed every 3 years. If they're over 30, you can do either cytology or co-testing every year, again for 3 years, and then every 3 years after that. So no more than 3 years in between. And this should be continued until really limited life expectancy. So if you have a 70-year-old patient and you expect, and she is HIV positive, or she's on immunosuppressive therapy, but you expect her to live at least 20 more years, then you should continue cervical cancer screening. So that is talking a little bit about the cervical cancer screening in the guidelines. I'm going to talk now on some at-risk populations, specifically our transgender patients. And I'm going to cover both cervical and breast cancer screening kind of combined here. So we know LGBTQ patients are less likely to have breast and cervical cancer screening completed. They do face more disparities in screening compared to cisgender females. And this may be for multiple reasons, but specifically for our transgender patients, they may be misgendered during a visit. The provider themselves may be uncomfortable. And during the exam itself, may end up getting inadequate or insufficient cervical samples. And this could be due to testosterone, the effect that it has on the histology of the cells, and also patient discomfort might make it more difficult to obtain an adequate sample. And that's for obviously the cervical cancer screening. So how should we kind of approach transgender patients? And really we need to start with us, working on personal awareness and what's our triggers? What are our biases and what worldviews? This is where implicit bias training or whatnot might come in handy for you. And then educate yourself. What is it that, educate yourself about transgender patients and terminology, making sure that you're using appropriate pronouns and discussing, being able to discuss gender identity and sexual orientation in a judgment-free zone. And then ask for permission and setting the stage before you perform any kind of exam. And really standardize and normalize your information gathering process. So a little bit more about screening for transgender patients. And I want to go back and say, I really appreciate the help of Dr. Melissa Davis with this. She is actually the director for our transgender clinic here at OSU. And I did ask for her help a little bit with this part of the webinar. So I wanted to give her a shout out. And so let's talk a little bit more about screening for transgender patients. So really the recommendations are based upon patients' current anatomy and then again, current guidelines based on that relevant anatomy. So transgender females with breast tissue and transgender males who have not undergone complete mastectomy should be receiving screening mammography based upon guidelines for cisgender patients and according to their age. When it comes to the exams, and specifically pelvic exams, providers really should be proficient in these techniques. And let's really work on maximizing patients' autonomy. So asking for permission, making sure we're talking about what we're doing before we do it. And hopefully this will help minimize that gender dysphoria and pain that they may then have during the exam. And again, I want us to keep aware of what's going on with the self swabs for high-risk HPV. This may provide a more acceptable evidence-based alternative to the provider-collected pap smears and thus make screening for cervical cancer in this patient population better. So we need to be looking out for some policy changes there. So more specifically here on transgender patients and screening guidelines, mammography specifically, there really is a lack of consensus. So there's not one statement out there. But in general, my research has shown that transgender women, so that they're on hormones or estrogen, they should start mammogram screening starting at the age of 50 if they have been on estrogen for at least 5 years. And again, they may need to start earlier, though, given any additional risk factors such as obesity or family history. And transgender men who have undergone mastectomy may also, and that's a complete mastectomy, they may want to consider having routine chest exams, given that mammography would not be possible in this situation. So these are just a little bit more specifics on mammogram recommendations there. So in conclusion, and it looks like I'm done a little bit early, so that's good. We'll have plenty of time for questions. But we need to keep on top of our evidence-based medicine here. So as research continues to progress, cancer screening guidelines are going to change. We've seen this even over the past 10 years, how much our cancer screening guidelines have changed. We need to also understand that depending on the guideline statements and who they're coming from, there's going to be different perspectives, thus having different recommendations. And so we need to make these decisions with our patients when it comes to what we decide to recommend, when to start, when to stop, and how to screen. And the last thing we need to do is just keep learning. So things like this webinar, so that we can stay on top of what the latest and greatest is in not only cancer screening, but everything else medicine will be best for us and for our patients. And that is it. Thank you so much for having me here today. There's some of my references, and I do believe that these slides will be made available on the OAFP website.
All right. Well, thank you, Dr. Panchal. That was wonderfully wonderful and helpful, and very much appreciate that. We've got some questions from our listeners. So the first question is, in addition to mortality outcomes, what information is available regarding morbidity? Does earlier and more frequent screening contribute to less suffering, such as physical, emotional, financial, etc.?
That is a great question. And I would say that the studies don't really look too much at, I mean, I'm sure there's some studies that are looking at morbidity. Again, they focus mostly on mortality. So I don't have a really direct answer for you on that. But what I would imply is depending on frequency of screening, you may see less emotional anxiety, physical harm, that kind of thing, just with the screening going to every 2 years instead of every 1 year. But again, maybe your patient is anxious and wants to be screened every year. So I wish I had a better answer and I had the research in front of me. I don't, but I do think it's mostly based upon mortality.
Thank you for that. The next question is, what is the cost for annual MRI screening starting at age 21 or 25 over a lifetime? Any idea? Not an easy question. Any idea of aggregate cost of screening for number of lives saved?
Oh my goodness. Okay, let me get my math calculator out. I don't even know. This is a really great question. And again, it's going to be individual, because let's talk, you don't even want to talk about insurance coverage, right? So what do MRIs cost out of pocket? I have no idea. But aggregating that over a lifetime, definitely cost prohibitive, right? And hopefully they have a really great insurance company that agrees with the recommendations. So aggregating that over time and number of lives saved, that's I'm sure that, gosh, I don't even know if there's a study out there that calculates all of that, and that would be a really good thing, I think, to look at. But I wish I had a better answer, but that would be a tough one to calculate.
These are tough questions.
They are tough questions.
Next one is, what are the Medicare payer recommendations as to how often a screening cytology or screening mammogram can be done?
Oh, Medicare. Medicare, of course, it depends on the type of Medicare, right? If it's Medicare for disability, that's a different than Medicare, the over 65 Medicare. They actually do, or Medicaid as well. So Medicaid does go off of the USPSTF recommendations are the baseline recommendations. So I think they'll even cover almost annually, but at least every 3 years, they will definitely cover it. So they stick with the guidelines on that. And including the mammogram, actually screening mammography, the last I checked, is still annual, that they'll actually cover it.
Great, thank you. Now this is kind of funny. So before we were starting, Dr. Panchal made the comment that I'm going to give her a hard time about now, that she was excited to have a discussion that was not going to involve COVID. And famous last words. So we're going to blame Dr. Sevilla for this one. And he asks,
I might have to tweet at him later.
Yeah, we'll give him a hard time. What is the recommendation about when to obtain screening mammogram following COVID vaccine dose?
All right. This was not covered because I swore I would not talk about COVID, but here I am. You do not have to delay. There is no reason to delay screening for mammograms after COVID. I know that there is some stuff out there about, lymphedema and everything, but there are no recommendations at this point to delay cancer or delay mammogram screening specifically after the vaccine.
Thank you for that. Has ACOG weighed in yet on the new PAP guidelines?
Actually, yeah. So ACOG is really in line with ASCCP. So they actually are part of the ASCCP, and they are along the same lines of those guidelines. But I will say that I have seen that practically. So people who are practicing are a little bit slower to immediately get in line with those guidelines. So even now at Ohio State, our cytology, we only do co-testing. We don't have primary HPV testing yet. Or if we do, we have to really go through some hoops to get it ordered. And so even whenever we do the cytology and you have to ask for the HPV testing, it still gives that over 30 only for the HPV. So there's definitely some catching up that in practice we have to do yet. Good question.
Thank you.
Yeah.
And next question. Most of the language used when talking about breast cancer is cisnormative and heteronormative, specifically talking only about risk factors for women and or presuming heterosexual sex practices. What can be done to make the language around breast health more LGBTQ plus positive inclusive?
So I think that's a great question. And I did just very briefly kind of touch on individually as physicians being more inclusive in how we're discussing the cancer screening. And it is really, I think, going to be a journey for everyone involved in medicine, as far as how we, what we say, and how we are inclusive in our language, so that we can encourage all of our patients into these cancer screenings. And again, I think that will help with comfort, as well as with our patients. So I think it really comes down to education, and us as providers being aware of our own limitations and our own biases and worldviews, and being intentional in what we say and how we say it. And I think that, not being part of that community myself, I would really love to be guided by those who do identify in that community, LGBTQ plus community, to guide the discussion about it. But I know that we need to have allies as well. So hopefully I'm being an ally now in that, hopefully.
And I think that raises a good point. I think, I know I've been in a position where I've talked to patients and I assume something, and it's like almost as soon as it comes out of my mouth, I'm like, oh, you should.
Yeah, exactly.
And, and I think one of the things I have found is just own it and apologize, like, hey, I'm really sorry. I should not have said that. Yeah. And I think, honestly, I find that just owning that, like, makes people really kind of soft, right. That I think they almost have an expectation that we're not going to apologize. We're just, when, hey, we make mistakes. And
right.
I'm sure we've all probably put our foot in our mouth at some point. And if you do, just apologize, own it, and move on and try to do better, and
exactly.
And there are times, and if you don't know, you can ask your patients to help. Like my first transgender patient was several years ago, and I just didn't feel like I knew what I was doing, and so it was very much hey, like, I was just straight up with her and said, hey, I don't have a lot of experience here. Like, and this was also in a very blue collar, traditional, like, area, and said, hey, I just don't have a lot of experience here. Like, I am learning as we go. If you're okay with that, I will do my very best to learn with you. And, and this was very early in her transition. So she didn't know a lot either, so I think we just need to own where we are and work with patients where they are.
I agree. I agree. And with that completely, my patients that I actually have a good population of patients who are lesbian, and they have been so informative for me, just talking with them, and as far as just, whenever we're addressing them and whatnot. So yeah, thank you for that question.
All right.
So something popped up.
Our question. I'm gonna ask some, because and actually one of the questions is, and I'm going to follow Dr. Savilla's lead. And sorry, Dr. Panchal, but okay. I was going to say, I'm sure many people have seen like their screening numbers just kind of go with COVID. And was wondering if how you're handling, getting patients kind of back in the breast and cervical cancer screening regimen, routine. How you're doing that?
I think that's really a great question, and I will actually, I'm not treating it any differently now at this point than I did before pre-COVID, right? So when they're coming to see me, I'm asking them, I'm making sure that they're up to date. And if if they need their cervical cancer screen, we're going to do it at that appointment, if they're, okay with it. And mammography, I know that we have a great just health maintenance thing that pops up on our EMR system that continually reminds us that they need to get their screening done. And that's also very helpful. So, but really talking with the patients about how wearing their masks and everything that we're doing really seems to be protecting the patients. So I found more and more over the last, several months, especially since the vaccine has come out, that our patients are definitely more willing to go through with these more preventative care things than they were, say, 10 months ago. So.
Absolutely.
Yeah.
Now, I'm sure some of our audience is probably saying, you know what, I am a busy family doc. I already have, 18 things I got to do at the visit. I'm this is I really wanted to take great care of my patients, but I don't have the time like to do everything. How do I do that? And so I'd love to hear any thoughts, strategies, how you can do this in a time efficient way, or to utilize the rest of your team, your medical assistants, LPNs, RNs, to help make sure your patients get the care that they need.
Yeah, absolutely. So, we're lucky. We have core care coordinators in our office that are kind of keeping an eye on the cancer screening, specifically breast cancer screening and pap smear, and cervical cancer screening in our patients. And we, with our EMR system, we're able to kind of, track that. So that's really helpful that we have care coordinators kind of calling patients and getting them in for these screenings. But also when a patient's coming in to see me and my medical assistant notes that they need this, they'll ask them, hey, do you want to get your pap smear today? And I think that is good to have kind of that available, because if you're comfortable, if the patient already knows you and is comfortable with you and they're ready for that pap smear, whether they're talking to you today about diabetes or not, I think it's an easy transition if your MA is already talking with them about getting prepared to do a pap smear. And if you're able to do it at that same visit, I think it would, be great for the patient as well, so that they don't have to come back. So really, doing that pre-planning, pre-visit planning, and then utilizing the MAs before you even get into the room about talking about that cancer screening that they're due for is important.
Absolutely. One of the things I often have done is have my medical assistant ask beforehand. And even if they say, no, I'm not going to do it, I find that when I go in and ask them the same thing that my medical assistant's already done, they're far more likely to say yes or be more willing, because it's
that happens with the
okay, I'm the second person. You're the second person who's told me that I should have a PAP.
Exactly. Yeah, maybe I should think about that. Happens with me and my MAs and me all the time with flu shots.
Oh, I was about to say that's
like they don't want it, and I'll go in. I'm like, nope, we're doing the flu shot today.
And they're like, oh, okay, you said, your medical assistant, she said that too. I should do it. And I come out and I'm like, oh, they need a flu shot. And they're like, but they told me no, I really did ask. And I'm like, I know you did. That's why they're getting it today. Good job.
Exactly. Like sometimes it just needs that extra little push.
It's like opening you got the jar like just loosened up.
Yeah, exactly.
So Dr. Sevilla asks, not sure if Dr. Panchal would know, but does she anticipate any significant female cancer screening guideline updates this year or next year? So this is a crystal ball question, which is really hard because the world's all upside down. Who knows what to predict? But we're going to ask you to predict anyway, Dr. Panchal.
Well, I think we need to stay tuned to the USPSTF, because they are actually in the process of changing their breast cancer screening guidelines. I'm not sure it's going to be too much different from what it is now, but I think they'll probably add some additional recommendations, maybe for different age range. So that I think is coming down the pipeline. Cervical cancer screening, I think the USPSTF will probably take a look at the ASCCP's new guidelines from this past year and maybe update their own too down the pipeline. So that's my crystal ball right there.
Absolutely. And I see a comment in the chat about pre-visit planning. I think this was on our last question. Either the physician or with help of care managers. I think that's an excellent point, because if you don't have that, it's so hard to think of everything at a visit. And if you know up front that you need to ask about the mammogram or their PAP,
right?
I mean, the MA can go ahead and ask that, at the beginning while they're rooming the patient, and then to follow up on it. Exactly. But if you don't have that kind of ahead of time in your game plan and pre-visit planning, you're already kind of behind the 8 ball. And when they ask about their depression and their back pain and they've got moles to check, and
by the way, I'm having
questions about vaccines and all of that.
Exactly.
Yes.
So even getting it ordered, even putting it in that order, like that'll help trigger that conversation. So
one of the things we've done is we'd have any patient who is due for a mammogram, my care coordinator would actually print out that mammogram order, and my medical assistant would often go ahead and give it to the patient.
Yeah.
before I even went in. And I'd see it, and I'd be like, hey, you got your order. Good job. Go get it done,
It's like, I didn't have to do anything. This is great.
Oh yeah. The best thing is when, the patient gets what they need and you don't even have to spend time doing it, that your team does it. So,
good teamwork right there. I love that.
Absolutely. Well, on that note, Dr. Panchal, thank you for your time and your expertise. And we really appreciate all that helpful information. And hopefully that will allow all of us to do a even better job taking care of our patients. Bear with me here.
Thank you so much. I really appreciate you having me here and giving me the opportunity to speak to you guys today.
Absolutely.